We're at 35. Looks pretty good, right? I think. Should be good to go. Okay, I'm going to start the intro. If everybody can admit people as they come in, we will get started. So thank you for those of you that are joining this breakout session. This is specifically for the teams that are currently part of the pilot, but I see that there are a few of you that joined that didn't want to go to the other one. That's okay. Just keep in mind that this is the last segment of our CMM webinar series. So you have skipped all the pieces that built up to this. But I know many of you that have signed on, I know that you have a lot of experience in CMM. So this could be worth attending as well. So I have no problem with that. We are very privileged to have Dr. Nader Tossoun here as the speaker for our session. I actually met him a little while ago, a few years ago now. He's the lead ambulatory care pharmacist at Northeast Valley Health Center, one of the largest community health centers and FQHCs in the nation, dominates the San Fernando Valley area. Dr. Tossoun received his PharmD from UOP, did a residency with the VA San Diego, just has a remarkably broad depth and breadth of experience in CMM, and has graciously agreed to be part of our pilot as well. So being that he's got some great experience in this population that we're serving, we asked him to share his own experience about keys to providing effective follow-up care to these patients. So Nader, please take it away.
Thank you very much. All right, thank you everyone. I know it's been a very long day, and I'm the last speaker, so it's usually around this time when people are dozing off. So I'm gonna try to keep it as engaging as possible, and we'll just go ahead and start. Let me see. All right. Okay. So it's just a statement of disclosure. I have no financial relation. Let me try to. The video is sort of, there we go. Okay, perfect. Sorry, the video was blocking the entire PowerPoint, so I couldn't see what was there. So yeah, so I have no financial relationship that apply to the educational content presented. So at the end of this talk, I'm hoping that you will be able to select an appropriate frequency of follow-up based on individual patient and clinic needs. Also, you'll hopefully be able to leverage other individuals or strategies to provide effective follow-up care and monitoring. And finally, we're gonna try to establish a system for patients to contact pharmacist providers regarding home self-management and monitoring results. So here's the pre-test. I'm not sure if you guys already have these questions up.
I think in this case, because it's going to be shared afterwards, we can just quickly go through the motion.
Sounds good. All right, so we'll start with the patient case. So this is something I always tell every student that I precept. Your patients are your best teachers, and what better way to teach than actually having an actual patient case. It actually makes my life easier, because I am able to just copy and paste and make minor adjustments, and actually have a real patient case for you that was very recent. One of my patients that demonstrates the importance of effective and frequent follow-up. So as you can see, this patient, I met her on March 26th, so right around when the lockdown started happening. So you'll see that this is a virtual visit. This was relatively new to all of us, but it actually shows how important it is to have continuous follow-ups, especially if you're not meeting face-to-face with the patient to establish that rapport, and how it's still possible to help our patients even virtually, even through the phone. So MG is a 54-year-old female Latino woman with a past medical history for diabetes, diagnosed in 2014. And ever since she's been diagnosed, she was never under control. She's never had her A1C under 7%, which was her goal. And you just kind of see it. She was pre-diabetic, and you just kind of see it creeping up. It just keeps creeping up. And it finally got to a level where it was around in the 9%. So just a little bit about her. She's uninsured. So she is ineligible for Medi-Cal or any other managed care insurance. So she's on a 340B program. And she works part-time at a school, but really she takes care of her grandchildren. She lives in a multi-generational household, which is very common in her community. And she lives with her husband and her adult daughter's family. There's no smoking history, no alcohol history. And over the phone, during our interview, I asked her about her glucometer readings. She checks mostly in the morning, and she's just reading them off to me, all in the 200s when she's fasting. She has 1 p.m. reading up in the 400s. When we look at her medication history, she's been on metformin, glimepiride, pioglitazone, all those medications for the past couple years, and really no changes. If you actually look at the trend of A1C, so this is something that's very important to look at in terms of lab values, is just seeing how she's trending. In 2019, she reached her highest A1C, which was 9.5. It was, so when I was talking to her about that, it was at that point where she was scared. So she did this sort of low carb, very similar to a keto diet, where, starting in April, and then by the end of August, continuing all her same medications, she was able to get her A1C down to a 7.4. So she did some good work, but then, the holidays showed up. If you know anything about this community, especially around December, we call it tamale season. It's something that is made with all the festivities that are happening December through February. And, she couldn't resist. She kind of fell off the wagon, and her A1C started creeping back up again. And it was 9% in February. And then she was referred, and then I met her for the first time on March 26th. So a little bit about this patient, you could tell that, she's very motivated. She's trying to make lifestyle changes, but, she just needs a little bit of help. So, this brings me up to the follow-up. So I looked at her history. You'd expect a patient like this to have frequent follow-ups, especially with an A1C of 9%. But she really, for the past year and a half, she only had, before she was referred to me, she only had 3 appointments with a healthcare professional. And if you actually look, and this is actually very common that you see in their notes, that it pretty much feels like a copy and paste. Patient declined medication adjustment and insulin. They tried to talk to her. She didn't want to make any adjustment. And then they just kind of give her, okay, lifestyle change, take your medication, bring a log, and then I'll see you again in 3 to 4 months. So you'll see she had an appointment in May 2019. Then she didn't see a provider again until 4 months later, September. And then she didn't see a provider again until February. Nobody was really following up with her. And that's, it's a very common trend you see in our in this patient population, especially in an FQHC where it's access to care is very, very difficult. So this is where we come in. So what would you recommend for this patient? So we look at the ADA guidelines, and where I want to direct you to is this new little pictogram in the ADA guidelines. It's pretty new in the past couple of years, and this is probably the biggest problem that this patient is facing, what we call therapeutic inertia. So you'll see that the ADA is now starting to take a huge stand against therapeutic inertia. So what is therapeutic inertia? This is basically when a patient is doesn't have frequent follow-ups, and even when there is a follow-up, nothing is being done at the patient appointments. It's very common in a healthcare system that that prioritizes numbers of patients seen rather than the quality of care seen. So what you have is you have a providers who have a crammed up schedule, and they're seeing many, many patients in a day, only having really a few minutes with each patient, and a patient who needs a little bit more education, a little bit more hand-holding. They're not able to offer that time, so they just go to, okay, here's the recommendation. If you don't want it, okay, we'll just see you in 3 months and I'll follow up. And nothing's really being done for this patient. The ADA actually recognizes this as a huge, huge problem in our diabetic patient care. This is why A1Cs continue to increase. You'll see that the ADA actually started an initiative called OTI, Overcoming Therapeutic Inertia. There's the website there, and they have a ton of resources that you could look up. And the whole goal of this initiative is to usher a paradigm shift in the care of type 2 diabetes, advancing the latest leadership, resources, tools in helping overcome therapeutic inertia in primary care. And again, the whole point of this is helping our patients live longer, healthier lives. So we could see that this patient is someone who, who the healthcare system wasn't able to help because of the way it's set up, and now they're referred to us. So I just pretty much screenshot my assessment and plan. So this is a patient with a 9% A1C, and you'd be surprised. I thought, okay, this patient's never been on insulin, she's going to be very resistant. Really, all it took was like 30-minute discussion and education and talking to her, and she was all in. She's like, I'm going to do, you obviously care. You've spent more time with me than any of my other providers. I trust you. Okay, if this is what you think I need, I'm going to do it. And it was actually very relatively easy to start her on insulin. So we started simplifying her med regimen. We stopped the Actos. A lot of these medications have long-term consequences, and I wanted to simplify her med regimen. It was kind of a tit for tat. I started Novolin just because she's uninsured. It was one of the cheapest basal insulins we could give her. So now let's create a follow-up plan for this patient. When are you going to schedule her next appointment, and what resources can you use? So let's talk about scheduling follow-up. So this is extremely important. The most important thing I could tell you about follow-up is make it adaptable for the patient. It's really about patient-centered care, and it really depends on how the patient presents. So if you have someone who's initially just a little bit more acute, for example, let's say they're presenting with patterns of hypoglycemia, or their blood pressure is up in the 180s, 190s, you probably don't want to make a medication adjustment and say, okay, I'll see you in 3 months. You probably don't want to do that. Our recommendation is probably 2 to 7 days is actually very, very reasonable. As they start improving, you could kind of push it out a little bit more, but usually no more less than a month. So I personally like to do 3 to 6 week appointments, but preferably every month. Once we start getting them on a pattern and seeing those improvements. And then after goals are achieved, because of the demand versus supply, there's not a lot of clinical pharmacists, but there's a whole lot of patients with diabetes in our clinic. What I do is I quote unquote discharge them from the program, but it's not that I don't see them, but I have someone else, like a clinical pharmacy technician, or in my clinical setting, it's the family medicine care coordinators. They're kind of health educators. They're sort of my right and left hand in these cases. And they will follow up with the patient quarterly, making sure they're not falling off the wagon. And if they do, they help get them back on the wagon. And if for whatever reason they need to be rescheduled with me, at least somebody's monitoring them. And it's pretty much their whole job is to monitor those patients so they don't fall off the wagon. So what is the secret to success of clinical pharmacy programs? So we've had tremendous success in our clinical pharmacy programs. We've seen, in the past 4 years at my clinics, over 1,000 patients. And when you look at the average rate of lowering of the A1C, it's about 1% a month. We've done great, great work. So I'm frequently asked by the CMO, the providers, what is the secret to success? Now, I think it's multifactorial. Obviously, you have a clinical pharmacist who I think is the best equipped professional to handle medication management for these patients where their diseases are mostly treated by medication. It just makes the most sense. But I would say the most important thing, in my opinion, is accessibility. And this is actually, I would say this is the reason I personally chose pharmacy. When you look at every other healthcare professional, the most accessible healthcare professional is a pharmacist, right? If you need to see your doctor, you have to make an appointment, you call, you don't get a hold of the doctor, you get a hold of the front desk, and you don't see them for a couple of weeks. And, it's not easy to talk to a doctor. It's not easy to talk to a nurse. You have to make these appointments and schedule, and there's front desk. But anybody could walk into a pharmacy at any time and get their questions answered. And this is our secret sauce. This is really what I think differentiates pharmacy. This is why I chose pharmacy as a profession, because we are just accessible to the patient. And so when it comes to clinical pharmacy, we have to use one of our strongest tools, which is really accessibility. If that means extending your hours a little bit, maybe a little bit more weekend availability. If on the weekends you close at 2 o'clock, maybe open till 5 o'clock, your regular hours or something like that, just to have more time to be with those patients. it makes a world of difference for the care of these patients. The next step is to identify your team. You know, there's a quote that says, "A talented group is better than the sum of all parts." It's pretty much means 1 + 1 is not 2, it's 10, right? And so when it comes to this is you want to find what is accessible to you, who is accessible to you to help you take care of the patient. And you know, you want to collaborate with nurses, health educators, care coordinators, nutritionists, therapists, whoever is available. The best way to probably go about this is to actually go to the health centers and the clinics that your patient goes to and see what resources are available to them. Also, if a lot of them are LA Care patients, I know that LA Care offers a ton of resources to their patients, and all you have to do is make a phone call and find out what resources are available to them. You want to engage family members and caregivers as much as possible. Actually, whenever I have a patient come in and I see a family member come in with them, in my mind, it automatically clicks like, oh, this patient's going to get well faster than a patient who doesn't have a family member with them. It's always kind of a sign of hope, because what happens is you get much more engagement, you get much more support when you have a patient and then his wife comes in, because turns out his wife is doing all the cooking at home, and then you're able to talk to them both at the same time, and it becomes a collaborative effort for this patient's health. So really try to engage family and caregivers whenever possible. Consider selective home visits or partnering up with healthcare team members who are already visiting the patients at home. I got to witness this back when I was in high school. I was a clerk at a pharmacy, and the pharmacist was a huge mentor for me. And what he would do is during flu season is he would actually come up with a list of patients that he would drive to, and actually, you know, he had his like vaccine toolbox and he would take me with him, and we would actually give vaccinations at the patient's home. He would just, they would organize it so that it was a group of patients that lived in very close proximity. And what that did for his pharmacy is it just created this relationship, this trust, this loyalty that the patients had for this pharmacist. And if we're able to apply some sort of similar approach with our clinical pharmacy, like our patients right now with our clinical pharmacy patients, it will just really, really help, because what you do is you establish trust. If you establish trust, you get this collaboration. You're now a team with the patient. The patient knows that you have their best interest at heart, and they are more likely to trust your recommendations, more likely to adhere to your recommendations. And then with that, you get better outcomes, and the better outcomes is just longer, healthier, happy lives for the patient. So it's a win-win situation. So consider that. If you're unable to do that, especially around these times when we probably should be socially distancing, see who is, so, you know, there are some social workers who go, try to link up with them. I remember when I was in the VA, we had this intensive program where I would go with, there would be these patients who qualify for home nursing visits, where the nurse goes and helps take care of the patient. And I would actually be able to go with the nurse for one visit, teach the nurse what each medication is for and how to do the pill box, so that every week when the nurse goes visit the patient, they know how each medication is supposed to be taken. You know, just having your presence there makes a big difference. And patient empowerment. I know at the last learning sessions from last year, we had, I forgot her name, but she gave one of the best presentations on motivational interviewing. You really want to use, who was it?
Dri Wong.
Yeah, she was one, like, so if you guys could refer, if you came to last year's learning session, refer back to those slides. I actually, every now and then, I kind of look back at them just because they were very, very, very good. And motivational interviewing really does work. You want to use ORS, if you remember what that is. It's open-ended questions, affirmation, reflective listening, and summarizing. And really, the whole point of patient empowerment, motivational interviewing, when you're talking about follow-up, is you're shifting the responsibility from yourself to the patient, and you're empowering the patient to help take care of themselves. right? And it's shifting this mindset like, oh, you're going to save them, you're going to, sort of this authoritarian sort of role as a healthcare provider. And instead, you're a coach. You're letting them know, listen, whether you get better or you don't, it's really all up to you, but I'm here to support you in whatever you need. Use a lot of positive affirmation. If I tell a patient to check their blood sugars every day and they only check it 2 to 3 times a week, I celebrate that. It's like, I always tell them how proud I am of them. Like, this is really going to help us figuring out the next steps to help get you closer to goal. I'm so glad you did that. And you'll be surprised. They take that positive affirmation and they kind of want to make you prouder and they start checking their blood sugars a little bit more. Just keep it positive and really establish a system for patients to contact you guys for home self-monitoring and monitoring results. Again, this just comes in with the whole idea of accessibility, just being there for your patient. A huge part of patient empowerment is letting them know you could do it, but I'm always here for you. You kind of don't want your patient to sort of kind of go renegade and just do their own thing. You want to empower them to make healthy lifestyle choices, but you're always there to as a support, and patients knowing that you have their backs feel empowered to really take a hold of their disease states and help themselves get better. You want to, so something that I personally do is based on how the patient presents for the follow-up sessions. I've created some patient-centered tools. So this is a blood sugar log that I created. I tried to make it a one-size-fits all sort of thing. I would put their medication regimen here. I would maybe sort of draw it out. And okay, in the morning, you're going to take these pills, and in the afternoon, you're going to take these pills. So, I leave a lot of space here to draw out their daily medication plan. This is just to remind them of their goals and what a healthy plate looks like. A little reminder of what they should be doing exercise-wise. And really, patients hold on to this. They fold it up. They put it into their little pouch with their blood sugar monitor, and they're constantly referring to it to remember what to do. And then you would tell them which, you would circle which readings you want. Like, oh, I only want you to check your fasting and pre-dinner for our next appointment. Just do it every other day. And they'll go ahead and do that. If you could offer pill boxes to your patients, really use their technology. Some patients do have smartphones, so you could help them set up daily reminders on when to take their tablets, and go ahead and just do it for them. And they do appreciate that you're sort of trying to look at every avenue at their disposal to help them. And I just want to add this section for virtual visits, best practices, something that I've personally done, especially in this era of COVID, of lockdown and social distancing. Virtual visits have, I'll tell you, last year I did 0. This year I do maybe, I see maybe 13 to 15 patients a day, and about 7 to 10 of them are over the phone. So it's just completely changed the way we approach healthcare. So I wanted to share some best practices that I've done in my own work. So one, you want to delegate someone in your team to call the patient for appointment reminders the day before. So I have my personal assistant who calls the patient and just make sure that they're confirmed, and it helps with lowering the broken appointment rate. Remember, 3 phone calls is not a golden rule. I think it just comes from baseball, 3 strikes and you're out. But when it comes to their health, you don't want to give up on them, right? You want to continue calling them. Just yesterday, I was working yesterday. I had a 10:45 patient who didn't pick up, and I called her 3 times, and then I called her once every hour. I finally got a hold of her at 4 o'clock. And she was so thankful. She's like, oh, thank you so much for calling. I got called. So she's a cleaner, and she just got called in for a job, and especially when money's tight nowadays, she had to take the job. So she went and did the job, and then she finished around 4. So when I finally got a hold of her at around 4 p.m., we were able to conduct our appointment at that time. So just don't give up on them. Just continuously call them. A lot of patients, the way my patients have taken is like, wow, this guy really cares. This guy, he really wants me to get better. He's constantly checking up on me and calling me. And this actually brings me into my next section. I call it unscheduled check-in phone calls. So when I initially meet a patient, I kind of let them know that, you know, we do have our scheduled appointments, but every now and then I might give you a random check-in just to check up on you and see how you're doing. I'll tell you, the reason I personally do this is if I get a broken appointment, I don't like sitting down and doing nothing. I want to fill up that broken appointment. So if I can get a hold of the patient and I have an empty slot, I will go down my list of pre-approved patients who have said they would be okay with check-in phone calls, and I would call them up and check in. It's like, hey, you know, I know we have our appointment in 2 weeks, but I just thought I'd check in. Like, how is everything going since the last time I saw you? How are your blood sugars? And then they're like, oh, you know, thank you so much for checking in. Yeah, you know, the increase in insulin helped. You know, my blood sugars are now from the 200s to the 150s. And then I'm able to like, oh, so what's your lowest, your highest? And they tell me, I was like, okay, let's titrate it by another 10%. And then we're able to do that. And it actually, again, this is literally combating therapeutic inertia. We're doing the opposite. We're following up with the patient. The patient feels that you care. They're getting these check-ins, even unscheduled phone calls, and it's a way to just keep you productive, to not just sit around when you do have a broken appointment. So again, this is just a best practice I've implemented. My productivity rate at my clinic is always at 100% because of this. And also consider video conferencing. You could FaceTime, you could Zoom. My clinic uses Auto, which is something you might look into. So yeah, consider offering video conferencing. A lot of patients actually do like it if they're technologically savvy. They prefer it over just talking over the phone. Okay, so let's go back to our patient. So let's come up with the follow-up plan for her. So, if you remember, we had our initial appointment March 26th, right when the lockdown happened. Unfortunately, I didn't have an empty slot till a month later, but I did have the family medicine care coordinators. They're sort of my right and left hand. So we stopped the Actos, we started the insulin, and I had her meet up with the family care coordinator the next day in person, because mind you, this was over the phone, to teach her how to use the insulin. Then the family medicine care coordinator was able to meet with her 2 weeks later, and this is what I call a flip visit. What happened was the care coordinator was able to talk to the patient. They were able to start the insulin, and they were able, you could see it wasn't actually in person. It looks like it was over video. So, you know, they had a video conference, and she was able to get some blood sugar readings for us. And, you know, you could see that her blood sugars are a whole lot better from the 200s. It's starting to get better. Went up once because of a heavier meal. And what happened was when the care coordinator collected this information, she contacted me right away. And then in between patient appointments, what I was able to do was look at this and then I flipped her visit into a clinical pharmacy visit. She basically did all the data collection for me. I was able to call the patient right away. You know, it's like, hey, you know, I just talked to Laura and she told me how you're doing. I'm so glad things are getting better. These are the insulin titrations that I recommend. Go up to 9 units in the morning, 7 units, continue the metformin, continue the glimepiride. And mind you, I scheduled her 1 month in advance. So I have a follow-up with her 2 weeks later. So we did a flip visit, we followed up with her. So you could see the importance of continuously following up with the patient. The patient's engaged. There's no kind of this there's no gap in their care. We're consistently. You could see her blood sugars are getting good, kind of too good right here. You're starting to get some low blood sugars. So we see that she still gets some highs pre-dinner and some lows. So what do? I was like, okay, let's start simplifying her medication regimen. We reduced her, we cut her sulfonylurea in half. We titrated up her insulin. Just again, we're really fine tuning. She always has our phone numbers whenever there's low blood sugar, so she could ask us what to do for help, but she already knows. So she's gonna drink half a glass of juice and she'll be okay. And again, 1 month later after the patient comes back to me, she was able to do her labs. So this was in May, she got to do her labs. Her A1C dropped from a 9% to a 7.7 in really a span of 1 month, about a month, really, about a month and a half. We were able to get her from 9.0 to 7.7. And again, you see her blood sugars just improving greatly. I did notice there was one hypo right here. You see that one hypoglycemia? That was enough for me to say, just stop the glimepiride. And now we simplified her regimen. She's now on insulin. We titrated it up based on her blood sugars. We kept her on metformin. So we stopped the sulfonylurea, we stopped the actose, which could potentially have long-term consequences. We put her on a simple regimen of insulin and metformin. And what I did was, if you could remember, just because of the supply and demand, I quote unquote discharged her due to an A1C less than 8%. She has a PCP follow-up on August 2020. So I did discharge her in May, but I had the FMCC follow up with her monthly. And if there was any problem, they would let me know. The good news is there was no problem. The patient was engaged with the family care coordinator. We got, for the first time ever, she was controlled, and it really only took a few months. It took a few months to get her to an A1C of 6.5. And it really shows how much a clinical pharmacist could help, and especially how much frequent follow-ups, having effective follow-up care could really help out our patients. So with that said, let's get into our breakout sessions. I want you to practice a lot of the strategies that you just learned for this patient case. So JO is an 86-year-old male with a past medical history, significant for type 2 diabetes, hyperlipidemia, coronary artery disease, and hypertension. He was referred to the clinical pharmacist for blood pressure management. His labs are within normal limits. You notice that when you ask him, how did you get to your appointment? Do you drive? He said, no, my daughter drove me. I asked, where is she? She's in the car. His social histories, he's a widow. He lives with his daughter's family. No smoking history, he just drinks alcohol at social events. So you have his medication list and you check his blood pressure, and this is what you see. So what questions would you ask the patients? What is your medication? We'll put a little bit of clinical questions in there. What would you do with his medications? And more importantly, create a follow-up plan and try to incorporate as much as possible what you learned during this presentation in your follow-up plan. What would you do? What are some tools you could use? What are some resources you have? And what I like about breakout rooms is try to feed off each other's creativity. Be as creative as possible. And then when we break at it, discuss, have the scribe, and then when we come back, let's try to go through this case together. So is it Victor who takes over from here?
Yes, Victor's going to send this in, but actually, before you go, if you could take a picture of the previous slide and the next, so these two blue slides.
Yep.
Okay.
And we had a document prepared, but I'm trying to see, we have a little bit of IT trouble.
Should I stop sharing and then you guys want to take over if you have it on your screen?
No, you can show that.
Okay, so what should I do?
You're fine. I think everybody should be either screen snapshotting or taking a photo with their iPhone or iPad.
Okay, yeah, so quickly take a picture of this and let me know when to go to the next page. All right.
I think we're all good, guys. Yep.
All good, and then let's go. So you could take a picture of this page, and then we'll go to our breakout rooms.
Okay, and Victor's going to broadcast the question, so I think we're good. All right, so the breakouts.
Great.
Probably gonna ask him about. Oh no.
We were in the middle of question 2, Nader. Darn. It's a good case. Oh, Nader, we can't hear you. You're on mute. Yes.
Sorry about that. It automatically muted me. So I was asking, how much time do we have left to discuss this case?
We need to get back to the room by 4:30, unfortunately.
4:30?
So, but I think 10 minutes is pretty robust, right? Maybe
Yeah,
we can,
I think so
okay,
too.
good.
So,
You have fully until 4:30.
Yes.
all right. So let's share. You know, I was in a very engaging room. I hope they're able to share some of what we discussed. But anybody, anything that you guys want to discuss or want to bring up? So I guess the first question is, what questions would you ask the patient?
Why didn't your daughter come in with you?
Yeah, that was actually something we did talk about. Ask the patient, hey, you know, you always want to ask the patient, would it be okay if we invited your daughters? You know, you don't know what family situation's going on, but if they're like, yeah, it's great. Yeah, she's very involved. Like she would normally be very involved. Yeah, invite her over and get the family involved. Find out what medications she's been on in the past. What other questions would you guys say? Compliance, side effects, great. Yeah, I would ask what medications have you been on before? I see that for med changes, Eddie wrote ARB. That's good because she has CAD, so she should probably be on an ACE or an ARB. So find out why she isn't, or why he isn't, I should say. We talked about measuring blood pressure at home. So some of our group members talked about finding out if the health plans, and I think a lot of our health plans nowadays do cover home blood pressures. So you could maybe get a referral for a DME for a home blood pressure, so they could check their blood pressures at home. You know, you want to titrate their medication up. What other things would you guys want to ask or say or do?
My group kind of talk about, we want to ask how patient diet is like. What do they eat? Do they cook or just mainly, you know, like fast food? A lot of those has a lot of salt.
Yeah,
it may affect the blood pressure as well.
That's very true.
Even though the patient is 86 years old, we would ask to see what his activity level is like. You know.
That's right. You know, they could still walk, they could still exercise. There's no age limit to exercise, right? Even just to walk around the park or something. That's great. The other thing we did talk about was we noticed his blood pressure does go up to 180. So we wanted to see if this is an emergency case or an urgency case, right? So we talked about, you know, if his blood pressure is going up to 180, you want to ask any chest pain, blurry vision, weak, like, you know, any left or right side weakness, because that will be the difference between go to the ER right now versus, okay, let's make some medication changes and I'll follow up with you in whatever. So that actually leads to the next question. When would you follow up with this patient again?
We typically like to do 2 weeks.
Yeah, 2 weeks.
Yep.
I would, for this patient, a lot of these blood pressure medications reach steady state in around 5 days, 5 to 7 days. So really, the medication really will reach its max effectiveness before a week is over. So I mean, I actually wouldn't mind seeing him within a week. And if it's not with you, have maybe your technician call him up and say, hey, is it okay if you check your blood pressure for me at home right now? I just want to see what it's like. And if it's high, they could let you know, and then maybe you could make an intervention at that moment. So that's like or see if a care coordinator is available to reach out to the patient within a week. So I think, yeah, within 1 to 2 weeks is a good idea.
Yeah, with remote patient monitoring, I would like to have the patient have one of those remote monitoring blood pressure machines.
Yeah.
We can intervene a lot quicker.
Yeah. So see if a DME referrals Or see if you're willing to maybe donate a blood pressure machine to your patient, and say, or maybe a rental, right? You could have them rent out, or have them for $5 a month, have them rent out a blood pressure machine and give it back to you once they're at or something like that, you know, to see what options are available. Get creative, find what options are available. You could even just have them borrow it, right? So just a lot of little solutions. If they can't come into the clinic every week, maybe you could reach out to them at home.
So Nader, I think you already know this, but LA Care feels that the value-based payment is sufficient, that whatever the teams want to do, they should, including buy that blood pressure monitor, as it's a relatively low-cost investment.
I think so. I think each visit you get like $70, and then the Omron, what's it called? The
Omron is probably the most reliable and relatively cheap.
Gold standard, and it's only like $30. So, you know, one visit covers half the amount of that. So just something to think about. Plus, you'll get them to goal quicker. You'll get them to goal faster, so you get that value-based treatment. And they don't even have to walk into your pharmacy to help to get that done. So just something to think about. Again, just get as creative as possible. And, you know, since we have just limited time left, I do want to go to the pre and post questions. I want to see, is that okay, or do you guys want to?
Sure, that's fine. Yeah.
Okay. All right, let me get back here. All right.
Oh, I just wanted to add, Riona mentioned that she would see the patient within a week, but check in 72 hours. I think that's really not a bad idea, given this guy's 86 years old, right? And you never know what kind of reaction he'll have to a medication change. So I would second that.
I think that's a great recommendation. Yep. All right, so let's get to the pre and post test questions. So which of these is true when scheduling a follow-up appointment for a patient who is on insulin? A 2 to 7 day follow-up is appropriate if the patient's reporting nocturnal hypoglycemia. As the patient's A1C improves, 3 to 6 month follow-ups are recommended. When the patient is at goal, the clinical pharmacy technician should check up on the patient at least quarterly to assure the patient maintains health goals. A and C, or all the above? What do you guys think?
All the
And
above.
by the way, are we seeing the slide?
Oh, you guys don't see it?
Oh, yeah, we don't. Sorry.
Oh, sorry. I don't know how to get there. Let's see. Am I still sharing?
You're not sharing right now. No.
Oh, okay. That explains it. All right. Let me go back to sharing it.
Thank you. Perfect.
Let me try to. All right. Let's get that. So yeah. Let me read it off again. So which of these is true when scheduling a follow-up appointment for a patient who's on insulin? Is it A, a 2 to 7 day follow-up is appropriate if the patient is reporting nocturnal hypoglycemia? As the patient's A1C improves, 3 to 6 month follow-ups are recommended. When the patient is at goal, the clinical pharmacy technician should check up on the patient at least quarterly to assure patient maintains health goals, A and C, or E, all the above?
All the above.
You think all the above? You think 3 to 6 month
We
follow-up?
have a lot of D's in the
D.
chat.
I think it's D. I think A and C is actually the right answer. And the reason is 3 to 6 month follow-ups might be okay if you're a primary care provider in an FQHC where your panel load is over 1,000 patients. But if you have the availability to meet much more frequently, if you could meet them in 3 weeks, 2 weeks, based on how they, even if they're improving, let's say their A1C is improving and they got from a 9 to an 8, they're still uncontrolled. And if you have the availability, if you could still meet up with them and make some insulin, you know, it obviously depends. Like if they're on oral medications, there's really, you know, you could maybe have it much longer. But if they're on insulin, and then this patient is on insulin, you could continuously titrate them until they get to their goal. Improvement is not enough. We want to get them all the way to their goal. So I personally see my patient every month until I get them to their goals. So I would say A and C is the right answer for this one. All right. Okay, let's go to number 2. So family members are untrustworthy resources to help with a patient's self-management goals, and these duties should only be delegated to licensed healthcare professionals. They shouldn't be involved. True or false? What do you guys think? Yeah, I think everybody's saying false. Yeah. Oops.
It's true if it's your it's true if it's your own family.
All right, and I think you guys saw the answer to the last one, but I'll read it out anyways. Which of these statements is true? Pharmacists should empower patients to solve their own problems when they have questions about their insulin doses and rely on figuring out the answers to the questions themselves. That's how great of an that's how much you should empower them. B, pharmacists should encourage patients to call them whenever they think they are having adverse reactions from their medication. C, pharmacists should refrain from having their patients follow up with other care coordinators or health educators and persuade the patients to only follow up with themselves in order to simplify and consolidate care, not too many hands in the cookie jar kind of mentality. Or it is better to wait until a patient is able to make an in-person visit than opt for a telephone appointment, just because in-person visits are obviously way more effective than telephone visits. So which of these statements is true? Let's see. Oh, I'm getting answers.
B's.
B's, yes, B's is true. Very good. So, let's see. So yes, it was D, B, and B. And that's pretty much it. How much more time we have left? I don't know how much time we have left.
Unfortunately, I don't think we have any time. Steve, would you?
I was about to say congratulations for being the only person on time. Thank you so much, Nader.
I was
and
really trying to speed through
Started
it.
at a deficit too.
Look, the content was exactly what we were looking for, and I think your passion and commitment to ensuring that patients do well showed in this presentation. So I want to thank you so much for sharing some of the great work you do. I had a lot of thumbs up and applause for you. Thanks so much, Nader.
Thank you, thank you.
I appreciate it. All right, so we're gonna all go back to the main room, Connie. Is that the plan here?
Yes, and if you look in the chat, you can click on that Zoom link that Victor just added to send you back over there.
Great, thank you. Thanks, Nader. Thanks, everybody.
Thank you. Bye, everyone. Or see you on the other side.
Ta-da!